So, hi everyone. Thanks for coming today to the cardiology student teaching. Today we've got an IMT from Manchester, Sam Trewick, who's going to take you through atrial fibrillation. So I'll let you get on with it. Sam, thank you very much.
So, hi everyone. Yeah, so my name's Sam. I'm one of the medical trainees down in Manchester. I know this might be a mixed group from Edinburgh and Manchester. So what I was hoping to do is to talk to you a little bit today about atrial fibrillation, go through a couple of ECGs. I was hoping to make it interactive to a degree. So if people want to unmute and offer answers, that'd be fantastic. Or typing in the chat also is fine. But if you get interactive with me, it might be more interesting than just listening to me talk. Our learning objectives for today are going to be to try and understand some of the pathophysiology fibrillation and how that relates to some of the complications, apply our knowledge of ECG interpretation to help diagnose atrial fibrillation, and then understand some of the different management options there are for people that we see with AF. So first things first, what I was wondering is, can anyone tell me what AF actually is? What do we mean when we say AF? No takers so far.
Free to use the chat, everyone, as well, if you'd rather not.
Yeah, so AF, defined by NICE, is a supraventricular tachyarrhythmia resulting from irregular disorganized electrical activity in ineffective contraction of the atria. Now that's a complete mouthful and an explanation like that. So what I how I generally describe it is I say, you know, your heart is made up of
open the case then.
Two halves really. We've got the ventricle down the bottom. What should be happening is atria and ventricle, atria and ventricle. But in AF, what's happening is the atria is doing this, and that's really it. ECGs. I was wondering, and please feel free to put it in the chat, what you're looking for in an ECG that diagnose AF. Any ideas? Yeah, absence of P wave. Anything else? Irregular. Yeah. Anything else? So there's sort of three distinct things to look for, which you've sort of pretty much said. So you've got the irregular RR intervals, absence of distinct repeating P waves, and then irregular atrial activation. So that's good. Applying that knowledge now, I was hoping what we could do, and I think this would probably work better if one of you or each of you maybe unmuted yourself and just describe some of these ECGs I'm going to show you, and just tell me whether you think it fits with those sort of patterns that would make it AF, or if you think it may be something else. And through that way, we might be able to work on our sort of method and way of interpreting ECGs. So, I mean, if you want to volunteer yourselves one at a time, that'd be great. If not, I'll pick you one at a time. And just bearing in mind, they might get harder as we go. So it might be a good idea just to sort of volunteer first.
Sorry, before you go, what do you mean by irregular atrial activation?
So that when we maybe see one, but it essentially means that, you know, that you're not getting definitive P waves. So in a rhythmic way where there's the equal distance between. Does that?
But there should be no P waves, right?
No distinct normal P waves. But what is a P wave? What does the P wave mean?
Okay. It's a bit confusing when you say, yeah, I would just stick to 2 more than 3. But anyway, carry on.
Sure. Shall we look at this ECG? So who would like to just describe this ECG for me? So
Sam, I don't mind. Oh, sorry. I was going to say, Sam, I don't mind doing the first one if that's.
Far away would be fantastic.
So I'll present it like I was doing an OSCE. I guess that's most useful.
It'll be useful, yeah.
So first of all, obviously looking for ID and everything if we got the right patient. But then the first thing I look at is rate and rhythm. So the rate, I tend to count the number of Qrs complexes. That's 10 seconds, and then times that by 6. So just quickly do that. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. 27. So 27 times 6 is a little bit fast, and then you could, or you could just check how many you can times by, so on. So I'd usually use a recalculator, but it's a little bit tachycardic, I guess, first of all. Then I look at, is it regular? It looks pretty regular. And then are there P waves? It does look like there are P waves in League 2. They're pretty close to the T wave, though. It could be an odd T wave, but they're pretty regular. And since it's a bit tachycardic, they're probably overlapping a wee bit with the T wave. So I think there are P waves. You can look in the other, in V1, there's probably P waves. They look a bit actually converted in V1. So I think there's P waves. I don't think this is AF, and it's regular, which also goes against it being AF. Then look at QRS, it's narrow, so it's originating from the atria, so that's normal. And then look at ST segments, if there's any depression or any elevation, and they look pretty unremarkable. And then the T waves, there's no abnormally inverted T waves that I can see. They should be inverted in T1, but I'm not sure they actually are there. So that's a bit abnormal, but it's only one lead, not adjacent leads. So it looks like a probably sinus tachycardia, I'd say.
That's spot on. That's sinus tachycardia, and you mentioned it, and you went through it in quite a nice systematic way. I guess the only other thing that I try and comment on is just is to include the axis, and it's not have it when it's relevant. So I just make it part of my work through it. But other than that, you're on. So this is an example of a sinus tachycardia, and perfect. So moving on to the next one now. Who'd like to maybe offer an opinion? Oh, sorry, I'm just going on to your comment you made before about the sort of the T wave and the P wave. Yeah, you were spot on. As you get faster and faster with the sinus tachycardia, it can sometimes be difficult to distinguish between the sort of the P wave and the T wave, but I completely agree with you. It's sinus tachycardia. Moving on to the next one, would somebody else like to sort of offer a description of this ECG in a similar format? Is it Vanilla?
Yeah.
Yeah. Would you like to have a go at this one?
Sure. So this is, I'm going to go systematically. Of course, I don't have a paper, but in certain places it looks irregular. And there are P waves in V1. There is a QRS after a P wave, but it varies. The length of the PR interval is variable. The QRS is narrow.
Is there a QRS after every P wave?
There is. So let me. Well, not after every P wave, no. So it looks like atrial tachy. But your inferiors look like it's atrial flutter with a 2-to-1, but I would think this is atrial tachy.
You were right. It is flutter actually, because you haven't got all. It's a flutter with a 2-to-1 block, and the inferior leads, you're right, look a bit more, and it's not atrial tachycardia because there are some non-conductive P waves. And the other, you were right in saying that if you look closely, some of them are sort of slightly irregular, and that's just a reflection of it's not 100%, 2-to-1 conduction block. Sometimes it's sort of less than that. So it's just a 1-to-1 conduction, which there's a slight variation, but generally speaking, that's a 2-to-1 through the ECG. Again, I'd say you just need to be commenting on the axis there as well, because there is evidence of left axis deviation on that one. Can you appreciate that?
Yes.
Okay. Okay, moving on to the next one. Who's next on the list? Is it Sarah?
Just before Sam, it might be useful, just because axis is not something we tend to go into too much detail with
Sure.
at medical school, because it's it's quite harsh to ask what axis in exams in med school anyway. But it might be wise just to see why there's axis deviation in that last one.
Absolutely. I remember from medical school there was this sort of rule about the up and down in these 1, 2, and 3. I always used to really struggle to remember exactly what was up, what was down. So I think about there's a circle that you have to remember when you're first learning about ECGs, the direction of the electrical potential, if you can remember and recall back to that, and you can remember and learn the values for that. So lead 1 is 0, AVF is 90, lead 2 is 60, lead 3 is 120, AVL's minus 30, and AVR's minus 120. They're all divisible by 30. So if you sit down and just memorize that, it's quite helpful. And then what I do is I just look for the most positive R wave. That's the direction that the electrical potential is going to. On this, you can see that it's somewhere between lead 1 and AVL. So it's pointing in more of the left axis deviation. A sort of a lazy general sort of thing you can look at as well is AVR is positive. It should never be positive. That's an extreme axis. And also you can look at sort of, if AVL is quite positive, you can sort of think, well, maybe that is going towards the left axis. And if AVF is positive, you can think, well, maybe that's going towards the right axis. Like I said, it's useful just to learn that diagram and get in the practice of looking for axis, because it has relevance in things like right heart strain, patterns like that, which again, if you don't just look for, you won't see. Did I explain that? Sorry, I haven't included that diagram of axis because I didn't want to go off on a tangent too deeply into sort of ECGs.
No, that's great. Thank you. I've put the diagram in the comments for anyone that would like to see it.
Thank you very much. So moving on to our next ECG then. So who was next on the list there? Was it Sarah? Okay, so maybe Stephen, can you offer us an interpretation of this?
Yeah, absolutely. Can you hear me okay?
Yeah, perfect. Thank you.
Fine. So I think just using a systematic approach that we highlighted earlier on. Just looking at the rate, I think it's two ways to work out the rate, and as Graham alluded to before, because it's already the complexes. A brief count: 1, 2, 3, 4, 5, 6, 10, 11, 12, 14, 15. So it's around 90 beats per minute, so it's not quite tacky. Rhythm, as we've alluded to, it looks pretty irregular, perhaps irregularly irregular. And to comment on your axis, it looks like it's a pretty normal axis. 1 and 2 are both upright. I think that the things that are glaringly obvious or that point out more so than others are these what look like sawtooth waves, or like a pattern in particularly your inferior leads, the 2, 3 AVF, and particularly the irregularity between the way in which they're being conducted, so that you've got 2 sawtooths, 2, 3, 2. And my understanding in that context, it looks like it's a type of flutter with variable block, as opposed to a 2-to-1 like before.
Spot on. That's exactly right. And it's that sort of inconsistent conduction, that inconsistent block is what's leading us to have that sort of irregular pulse. So if you saw someone with this sort of pattern, you might feel their pulse and say it's irregular, and be thinking, you know, could this be potentially atrial fibrillation? But this ECG obviously is slightly different to that effect. But that's completely right. I'd agree with your interpretation. And then moving to this one, is it Suha? Potentially, you could maybe describe this one for us.
Yeah, I could give it a go.
Mm-hmm.
So I'm just gonna check the patient's name, date of birth, and if there's any ECGs to compare it to, then just gonna quickly calculate the rate, which is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. It's about 120 beats per minute. So the tachycardic, and just going to check if it's like a regular rhythm.
Mm-hmm.
And it seems to be regular, if I'm not mistaken. Just check the axis. And it seems to be some sort of left axis deviation, because these 1 and 3 are going away from each other. And then I'm just going to check there's P waves for each QRS complex.
Sorry, just to correct you, I think that would probably be right axis deviation rather than left axis deviation.
Oh yeah, sorry, they're reaching towards each other. My bad.
That's okay.
And there seems to be P waves before every QRS complex, so sinus rhythm. And then I check the PR interval, but I can't see closely enough to check, but it looks normal.
Okay. And just look, can you see my arrow? Can you see my pointer?
Yeah.
What about these here?
Is that an extra wave?
Yeah, so it's definitely another wave, isn't it? So what do you think that might be?
Is that a Q wave or a U wave?
No, it's not a U wave. It's another P wave, actually.
Okay.
So not every P wave is followed by a QRS is the important distinction to make there.
All right, okay.
Carry on with your sort of description.
Okay, so not every P wave is followed by QRS complex, which means there's some sort of heart block.
Yeah, there's some sort of issue with conduction, isn't there? Definitely.
And then just looking at the QRS complexes, and there seems to be quite large QRS complexes in V3 to V6.
Mm-hmm.
So some sort of ventricular hypertrophy.
But potentially, I mean, you'd have to count the number of squares to sort of definitely make that voltage criteria, of which we don't quite make it, but that, you know, there's a degree of sort of irregularity there. Certainly, there's a voltage criteria that you look at. It's sort of 7 combined with sort of V3 S wave and the R wave in V5 and V6. So it doesn't quite make it. But I agree with you. It looks a bit unusual.
Okay, all right. And then I would check the ST segments and all the leads, check if there's any depression or action.
Mm-hmm. So do you think this is AF? Because obviously it's irregular. Would you say this fits with AF, or do you think it's not AF?
Because the rhythm is regular, I would say it's and also there's P waves before every QRS complex.
Yeah.
It doesn't fit with AF. Spot
on. Yeah. This is sort of a common. Well, it's not that common sort of clinically, but you know, a good differential for AF, because the ECG has some non-conductive P waves. It's sort of slightly irregular. It's something called multifocal atrial tachycardia, which is something just to be aware of, but not something you'll see that often. It's this irregular rhythm of where you've got sort of depolarization coming from multiple areas of the atria, and that's why you've got P waves that are sort of different. So you know, there's like a negative P wave there and a positive P wave there. That's unusual. That's pathological, and you've also got non-conductive P waves as well. And the relevance of this really is that it's often seen in patients who are sort of acutely unwell and have sort of respiratory or cardiac problems pre-existing, and it's got an inpatient hospital mortality of about 60%. So it's a bad prognostic sign if your ECG sort of looks like this. But that's just one for interest to show you there. What about this ECG? Can anyone? Is it Salah? Can you maybe describe this for me?
Yes. So first thing I would do is, after checking patient details, I'd look at the rates. So 1, 2, 3, 5, 6. Perhaps slightly tachycardic. I'll just 13 times 6.
So 13 times, we say
78 beats per minute, so that's normal.
Good.
However, it does look quite irregular.
Sure, yeah.
And there are P waves before every QRS complex. So look at the axis, it looks like deviation.
So this is difficult because obviously lead 3 is still positive, and lead 1 is positive. So it's probably approach, but with a sort of a positive lead 2 deviation. So say approaching left axis deviation.
Okay, so it's axis deviation. And then the next thing I would do is look at segments. So PR interval, which see, and then I would look at the ST segments to see if there's any, or depression, which I think there is in V2 and 3, 4. I think there might be ST elevation in V2, 3, and V4 maybe. So
it's difficult. I think this is probably just a bit of high takeoff. I don't think that this is necessarily ST elevation. Let's say for the sort of the point of argument, just to believe me, if there's no ST elevation, the patient doesn't have chest pain, and our interest really is in the sort of the rest of it.
Yeah, sorry, carry on.
No, so I was going to say, you know, this ECG as well, then, so it's irregular. You might feel the pulse and think, you know, that's irregular. I get the ECG. Is this AF or is this something else? Do you know what this might represent?
It can't be AF because there's P waves before every QRS complex.
Yeah.
And you'd also probably expect tachycardia with AF. So we don't have that. Mainly the P waves being present is what makes me think there's no AF.
Yeah, that's so you're right. Yeah, so this is sinus arrhythmia. Firstly, on your point about the tachycardia, so not all AF has to be tachycardic. So don't use that as a sort of a way to say it's not AF. But this is sinus arrhythmia. You're completely right, because there's a P wave leading to sort of QRS complex. We can say sort of quite safely it's not AF. This occurs, this pattern is actually a normal variant in young healthy people, and you get this variation, this irregularity, mostly due to sort of respiratory effort, and it increases the vagal tone, which slows down the heart rate. And it's, like I said, common in younger people. You see it less in elderly people because that sort of baroreceptor reflex reduces over time. So that would be an unconcerning ECG to see, providing that you accept that there's not concerning ST elevation there from the sort of the irregularity point of view. But well done, that was really good. And then our final ECG, is there anyone else who'd like to just sort of interpret this? Is there anyone else left? Has everyone had a go? Fine. So I'll do this one then. So you know, this ECG, just counting up, we got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. 13 times 6 would be 78, so that's normal rate. The axis is sort of approaching the left axis there. I can't see any discernible P waves. I think it's an irregular rhythm. QRS is narrow. There's no significant ST segment abnormality. So I'd say this is atrial fibrillation. Does anyone disagree or have any comments on that at all? We happy and can see that? Fine. So moving on, sort of thinking about AF in general now. So who gets AF? What are the risk factors for that? If people want to put things in the chat or shout out on on the microphone. Age, yeah, no, age is a really important one. That's obviously really important because it's non-modifiable. We can't do anything about that. People who, you know, between the ages of 50 and 59, there's a prevalence of about 0.5%, whereas when you get up to between 80 and 59, prevalence goes to 8. There's a AF strokes. Yeah, that increases your risk.
Oh, Sam, sorry to interrupt
Yes.
you. It may just have been my side, but the last 30 seconds you cut out.
Oh, that's fine. So I was saying sort of heart failure and diabetes, yeah, they're all huge risk factors. Previous stroke, MR being mitral regurg, I'm assuming. Yeah, that is as well. Any lifestyle things that can contribute? Obesity, yeah, that's right. Alcohol, yeah, so alcohol, people who binge alcohol, they can have a trigger of knocking into AF, or patients that have got excessive alcohol use, so more than 14 units a week are also at risk of AF. I just put another few other risk factors down as well. So caffeine, recreational drug use, especially those that are sort of stimulant in nature, that they increase the risk. Smoking, slightly contentious. There's sort of mixed evidence to say whether that does contribute or not. And hypertension, heart failure, diabetes, obesity, they're the sort of big ones, along with coronary artery disease and hypothyroidism as well. I completely agree with you. So moving on to the sort of the pathophysiology, it's probably important for us just to think about that slightly. Although our knowledge of exactly why AF occurs isn't fantastic, and as you've all alluded to, there's huge variety of causes or sort of contributing factors to AF. But ultimately, the sort of the electrophysiological pathway that AF results in is all the same. So in normal physiology, we get our sinoatrial node, which leads to depolarization of the atria. That's then picked up by the AVN, which there's a slight delay, and then there's depolarization into the ventricles, and we get ventricular contraction. What's special about these atrial cells is that they've got a very short action potential, so they depolarize very quickly. And actually, as their rate increases, their refractory period, the period that they rest, actually reduces. So as they get quicker, they can get even quicker, and that problem propagates. There are two sort of theories of how AF occurs. The first is the sort of the focal activation mechanism, in which there's a sort of focal area where there's excessive firing, and this leads to sort of electrical activity that sort of disseminates around the atria. The other one is that there's multiple wavelets, and this is where there's lots of different areas of sort of cycling of electrical activity. And you get these re-entry mechanisms back into the atria that continue it to fire and fibrillate. And this is thought to be more associated, the multiple wavelets, with atrias that become dilated. There's an important mechanism to think about as well with the AVN as well, the AV node, because the atrial rate can go up to 300, 400 beats a minute. And what the AVN does is it's intermittently conducting those impulses. If there wasn't intermittent conduction, the ventricular rate would be as fast as the atrial rate, and that wouldn't be compatible with life, you know, a ventricular rate of sort of 300, 400. But this intermittent conduction leads to your intermittent pulse that you feel and your intermittent rate. And that's why your ventricular rate is often a lot slower when you've got somebody who comes in with AF, with rapid ventricular rate. It's normally sort of, you know, 130, 100, 120 or so. Is that clear roughly on the pathophysiology of atrial fibrillation? It's something to just be aware of rather than sort of knowing too much detail, really. I just wanted to think now about some of the definitions, the ways that we can sort of divide AF and describe it. So I'm just going to give one, each of the sort of the definition, and I was hoping that maybe people just suggest what sort of AF that describes exactly. So the first one is recurrent AF. Can anyone tell me what sort of the definition of that is? That's probably the easiest one to guess. Okay, so it's anyone who has more than 2 episodes of AF. What about paroxysmal AF? Can anyone tell me what that means? Not there all the time. So I wasn't sure if you meant that was me then talking, or you were talking about AF. But yeah, no, that's right. So you get recurrent episodes of more than 30 seconds in duration. But importantly with these is they have to spontaneously revert within 7 days to consider them paroxysmal. So longer than 30 seconds, but less than 7 days. Can anyone guess what persistent might mean? There all the time for longer than 7 days, more than 7 days constantly. Yeah, all right, yeah. So fails to self-terminate within the 7 days. And then you got this term long-standing persistent AF. Yeah, Sual, that's right. So persistent is greater than 7 days, less than a year, with long-standing persistent AF being AF for longer than a year. So what's permanent AF then? How would we describe permanent AF? Can't cardiovert. Yes, essentially that's right. It's when we accept that sinus rhythm is going to be there. Sinus rhythm can't be restored or maintained, and we accept that these patients are going to be in atrial fibrillation permanently. So thinking about our patient now, when they come into hospital, they often don't come in and say, I've got atrial fibrillation. What are the symptoms that they may present with? What do you think? Palpitations, yep. Anything else? Chest pain, shortness of breath, yeah, very good. Anything else? Irregular pulse, yeah, so sort of asymptomatic emission ECG, very good. So the most common symptoms that people come in with sort of relating to this will be palpitations, chest pain. Sometimes they can sort of say they're tired, they've not been well for a little while when they've had these palpitations going on for a little while. Shortness of breath, definitely. Pre-syncopal, so feeling very lightheaded, dizzy. TIA and stroke is obviously a really big one. Patients will come in with maybe some neurological symptom that's resolved. It's important for us to think, you know, could this be a TIA and actually they've got AF? And obviously, yeah, Graham's right there. Asymptomatic is also really important. Often this can be an incidental finding on ECG. So I've kind of alluded to the diagnosis. To detect this, really, you know, the way that we do that is with an ECG. But what happens if somebody says, you know, I had palpitations, I've come to A&E, there's a 10-hour wait in A&E, now that I'm seen, I've got no palpitations. Do we say, and we do an ECG at that point and they're in sinus rhythm, do we say, fine, this is not AF, we're happy, we've done the job? What do you do in that situation? How can we diagnose AF then? 24, 72-hour, maybe 24-hour monitoring. Yeah, that's right. We can set something up so that they've got a tape at home, and we call it a Holter monitor. And our decision of how long to monitor is dependent on how frequently they have the symptoms. If they say that over the last month they've had symptoms once a week, there's no point putting a 24-hour tape on them, because you've only got a 1 in 7 chance of capturing whatever symptoms they might have. So we've got options for sort of 24 hours, 48 hours, 7-day monitoring. Or if it's even less frequent than that, we can also insert a device under the skin called a loop recorder. And if they develop symptoms, that can detect the rhythm when they're having symptoms. So there are multiple ways that we can record and see if they're having symptoms. And it's all about symptoms and then the rhythm that we pick up. And that's the sort of the way that we clinch the diagnosis. So just thinking about sort of investigations that you might do, and I was thinking about this from an acute setting. Somebody comes in with atrial fibrillation, because as you've all alluded to, there are multiple causes for this, there are multiple things that can contribute. So there isn't a sort of a blanket set of investigations that you can do to once you've diagnosed somebody with AF. But when somebody comes in acutely with palpitations, or we pick up AF incidentally in the context of their sort of presenting complaint, there are a couple of things that I think are always useful just to do. So obviously, observations at the bedside and an ECG is going to help us with our diagnosis. From a bloods perspective, I'd always do full blood count, kidney function, CRP, and then looking at the electrolytes. Potassium is going to come in the kidney function, but looking at magnesium, if the magnesium's low, it might need replacing. And in the bone profile, looking at calcium, although that's less commonly associated to AF. And then also thyroid function is another one just to consider. Depending on the presentation and the history, you might want to think about, a troponin or a D-dimer. But I wouldn't be blanketing doing that on everyone who comes in with palpitations unless they've got chest pain or risk factors. It's certainly not something that we should just do reflexively. Chest X-ray is really important as well for sort of 2 reasons. Firstly, just to look at, there might be a concurrent chest infection that's driving a sort of an atrial fibrillation. Or also we want to have a look at the lung fields in general and look for any signs of decompensation from the atrial fibrillation as well. So does everyone who come in with atrial fibrillation need an echocardiogram? What do people think? No, yeah, that's right. I mean, there's sort of pretty ambiguous guidelines on NICE about who should, unless they have signs of heart failure. So yeah, certainly if they've got signs of heart failure, I think that would be reasonable to do an echo if they haven't had an echo before. NICE have got these sort of ambiguous guidelines that they sort of have published, which relate to echocardiogram with AF. So they say that patients who come in with AF or have AF they should have an echocardiogram if the cardiac function is relevant to their long-term management. And I'll come on to sort of talk about the nuances of that in a little while. If you're undertaking any rhythm control strategy, again, I'll talk about that soon. And if you've got any suspicion of any underlying structural or functional heart disease. So there you sort of your 3 reasons to do so. And your suspicion of structural or functional heart disease, that could be you listen, you hear a murmur, or they've got family history of some congenital heart disease or structural heart disease. And this sort of, when cardiac function is relevant to long-term management, it's quite a fluffy one that you can kind of fit any patient in, really, because you could always argue that their cardiac function is relevant to their long-term management. So it's always possible to justify it, but that's what NICE advise with regard to echocardiogram. So I suppose that the thing that's really important for us to think about when we're seeing these patients is what's the relevance of someone in AF if it's asymptomatic. Why do we care if the rhythm's irregular? And the main reason for this is really thromboembolism. What happens when the heart does this and beats really irregularly is that you can get stasis of blood in certain areas of the atrium. When that occurs, you can develop thrombus. if that thrombus within the atria, some of that breaks off, it can enter the systemic circulation and cause a whole host of problems. And you know, that includes, the thing that we always think about is a stroke and TIA, but someone with acute limb ischemia, so they might suddenly develop a pulseless limb, or a pulseless, a very cold finger. Acute mesenteric ischemia, so that's a blood clot that's in the within the bowel, or ischemic hepatitis as well, so a blood clot that's entered the circulation within the liver. So stroke risk is really the one that we think about most commonly, and is the sort of the basis of which we base our strategy. Does anyone know how we assess someone for a stroke risk associated to AF? Chad's VASC score. Yeah, exactly, that's right. So I'm not going to ask you to list, well, it's Chad's 2 VASC, but Chad's VASC here. I'm not going to ask you to list every single one of the characteristic, the criteria, because I myself can't name them all off the top of my head. I always use MD Calc just to work these scores out. What's important for us to think about, though, as clinicians, is that it's not just somebody's in atrial fibrillation, work out the Chad's VASC score, anticoagulate. There are a couple of other circumstances as well. So just because somebody is no longer in atrial fibrillation doesn't mean that we wouldn't necessarily consider them for anticoagulation. If they've got sort of paroxysmal symptoms, they're occurring regularly, we consider them at risk of going back into AF, and their risk of clot is high enough, we'd still consider anticoagulation. And also somebody in atrial flutter also should be considered for anticoagulation with Chad's VASC. And the importance of this, really, the sort of the evidence behind it is looking at this here. So down the bottom here on the x-axis is the sort of the score, and on here on the y is your annual risk of a embolic event as a percentage. And as you can see, as the score goes up, generally speaking, your risk of embolism goes up quite significantly. And the guidance around the use of the Chad's 2 VASC score has changed slightly in the new guidance. And all patients who score greater than 2 should be offered anticoagulation when balanced against their bleeding risk. And we should consider anticoagulation in men who score 1. And that's because you can score a point for being female, whereas a man would have one of these important risk factors that we spoke about. And sort of against that, really, we're sort of saying, do not offer anticoagulation for those under the age of 65 based on gender alone. And what that means is that, if you're a woman at the age of 25, if you use this score, you're going to score 1. They don't necessarily need anticoagulation unless they've got these other risk factors. And the other important thing in the new guidance is the statement, do not withhold anticoagulation based solely on age or risk of falls. What can sometimes happen is a patient comes in with multiple falls and we say, well, no, we really shouldn't be anticoagulating them. Or sometimes people say, this patient's quite old, their risk of anticoagulation is quite high, so we shouldn't anticoagulate them. But NICE are now advising it against using this sort of just rule of thumb, really, and they advise to use a slightly different method of deciding whether anticoagulation is appropriate. Does anyone know sort of a bleeding risk score, a score that we should be using to balance our decision to anticoagulate? Orbit score. Yeah, that's really good. Does anyone know any others? Hasbled, yeah. So Hasbled is sort of the being used more historically, but now NICE are actually endorsing Orbit as this sort of the score that we should be using when we're thinking about bleeding risk. And as you can see here, it's a score of 5 different points, but you can get a maximal score of 7. And essentially, the greater the score, the greater the risk of sort of a major bleeding event is. With major bleeding event being bleeding that leads to death, obviously quite considerate. Bleeding that leads to critical organ dysfunction, or bleeding that leads to sort of a transfusion of more than greater than 2 units. And the other important thing to look at when you're looking at the score and thinking about the score is most of these things aren't really modifiable. Your age, you're not going to be able to change. Bleeding history, you're not going to be able to change. And generally speaking, your EGFR, you know, there's sometimes some small fluctuations in acute kidney disease, but this is more related to sort of chronic kidney disease, so that isn't necessarily modifiable. So the only things you can change are transfusing somebody or stopping their antiplatelet therapy. And the purpose of this score really is just to look at and say, you know, you've got a 6.1% chance of having a major bleed in the next year versus maybe having a 8% chance of a stroke in the next year. And it's having that discussion with patients of sort of saying, you know, based on that, you're probably at a higher risk of having a stroke. You know, we feel that it's probably best to be anticoagulating you, but discussing that with the patient and involving them in that decision making is really important in this process. Moving on to the management then, what do people know about how to manage AF? There are sort of two broad camps. Can anyone tell me what they are? So there's two divisions really. It's rate and rhythm control. And I always remember when I was a medical, yes, spot on, rate and rhythm control. And I always remember as a medical student really getting stuck with, you know, who gets rate control, who gets rhythm control. I'd say generally speaking, in practice, what I've sort of noticed is rate control is far more common on the day-to-day general medical take. The sort of the reasons why somebody might get rate control are as follows. So it's you know, patients who are symptomatic with palpitations, patients who have got non-reversible causes of their AF. They might be in permanent AF, or there's nothing that we found in our investigations, like, you know, altered electrolytes. And also if they've been having symptoms for longer than 48 hours or definitely been having AF for longer than 48 hours, they're rate control in the first instance. Rhythm control is a bit more of a sort of a dark art really. And that's, in the first instance, definitely if somebody's hemodynamically unstable, we're opting for rhythm control with electrical cardioversion. If somebody has got a definite onset of less than 48 hours, then they can be considered for rhythm control. If somebody has got heart failure that we are confident is as a direct result of their atrial fibrillation, so they have decompensated purely on the fact that their AF is so poorly controlled, we can opt for rhythm control. If somebody has got ischemic chest pain, and we are confident that is because this atrial rate is going so fast, this is leading to sort of hypoperfusion of the heart, they can be rhythm controlled. And then also if somebody's symptomatic, despite the fact that we're rate controlling them, we can then opt for symptomatic despite rate control, we can opt for a rhythm control option. Does that broad division make sense? Good. So when we think about rate control, there are sort of three main drugs that we go for, and probably the three categories of drugs that we go for. And there's three that you guys should be aware of. Can anyone sort of give those to me? Beta blocker, yeah, and I'd say that's probably your first line choice. What else can we offer? Rate limiting calcium channel blocker, good. And anything else? Digoxin, yeah, spot on. And nice sort of say that for monotherapy, you would go for a beta blocker or a calcium channel blocker, and then you can add in a second agent if that isn't effective. Digoxin is not a fantastic drug for rate control, and really it should only be used in monotherapy for patients who are quite sedentary and aren't walking around a lot. That's sort of the advice that we give. But it is quite effective concurrently if somebody's got heart failure. Rhythm control then. So there are a couple of different drugs that we can, a couple of different strategies for rhythm control. There's pharmacological. And can anyone give me any drugs that relate to the sort of the pharmacological way that we can rhythm control somebody? Amiodarone. Yeah, anything else? Flecainide. Yeah, flecainide is the other one that's sort of discussed specifically in the guidelines. So when do we pharmacologically rhythm control someone? Well, in the first instance, that the patient has to be appropriate for rhythm control in the ways that we've said. So, you know, we've got a definite onset of symptoms in less than 48 hours. Those other indications for rhythm control, you know, acute heart failure, ischemic chest pain, hemodynamic instability, we're probably not going to be opting for pharmacological for those people. We're not going to be opting for pharmacological in those patients. So it's really those patients that we can say, you know, you developed your symptoms 24 hours ago, we've got a definite onset and you're very stable. With regards to the two drug options that are available to you, it is important in these patients, as we know, that we need to have an echo. If they've got a normal heart on echo, we can give them flecainide. And flecainide is quite a useful drug. It's a sodium channel blocker. And in patients who develop paroxysmal AF, where they're tripping in and out of atrial fibrillation, we can actually send them home with flecainide. And it's this pill in pocket regime that you can sometimes see described, where they develop symptoms and they can take a flecainide themselves. Amiodarone is a drug that can be used when you've got a normal heart function, but is also effective if there's evidence of heart failure as well, or left ventricular failure. This drug, the trouble is with that is it can be associated with some side effects like thyroid dysfunction. It's important to discuss that with the patient before we start it. The other option is our electrical cardioversion. And the real important factors here that we have to think about is whether we should be whether we need to, or whether we should anticoagulate someone before we do it. Electrical cardioversion has got its own risks. You know, you have to give someone a bit of sedation, put them to sleep before you can, or not fully asleep, but you know, sedate them slightly before we can do it, and that just comes with its own risks. Patients where we are not sure exactly how long the symptoms have been going on for, we often have to start anticoagulation on. So if it's been going on for a little while, but we still want to rhythm control them, what we might do is we might give them some rate control, anticoagulate them for 3 weeks, and then bring them back in about 3 weeks' time, and then electrical cardiovert them in clinic. If they are unstable, very low blood pressure, you just have to go for the electrical cardioversion, and you accept the risks of stroke. That's essentially what we're trying to offset by anticoagulating. For those patients who are stable enough to wait, but we can't wait the 3 weeks, the other option is to get a transesophageal echo to look for any evidence of a atrial thrombus. If there's no thrombus, then we can proceed with the cardioversion sort of in the acute setting. Finally, I thought I'd just very, very quickly just discuss these two additional therapies that we can have as methods of rhythm control. And this is more done in the outpatient setting. So the first is catheter ablation therapy. And it's a way of establishing rhythm control. How it works is we go through the femoral vein up into the heart, isolate often the trigger zone, which is often the pulmonary veins. And then there's a burning that occurs, ablation, either radio frequency or cryoballoon. And the hope is that will then prevent that spreading of the electrical activity in the atrial fibrillation. And it's found to be about 90% effective. Often what happens, like I said, is the patients, we put them on rate control, or we might cardiovert them electrically, and then they go back into AF further down the line. And this is a sort of the next step option that we can offer to them. Another option that is available as well, which again is just a little bit of interest really, rather than something you need to know much about, and that's the sort of the pace and ablate strategy, where if somebody's in permanent AF and they've got symptoms that are very bothersome, or they've got dysfunction, LV dysfunction, that we think is related to the fact that the ventricle is beating too quickly because of the atrial fibrillation, you can ablate the AV node so that none of the depolarization can be passed from that fibrillating atria down into the ventricles. And then to maintain a cardiac output, we then pace the ventricles with a pacemaker. So you sort of ablate and then insert a pacemaker. That was a sort of a general overview of atrial fibrillation there. Has anyone got any sort of final questions at all?
That was brilliant. Thank you very much, Sam.
No problem.
Maya also said thank you. So she had a fire alarm that went off, so she had to go, but she was enjoying it up till then. I just got to stop the recording there.